wanted now to give continuity to our agenda. And I think the first panelists we're going to have today are Mira Joy and Audrey Bollier, that will share a little bit their findings from their living scoping review on the zero-dose children literature. And that's going to be followed by Sunitha Chandrasekhar from Sabin, who will be sharing the synthesis of the call for abstracts, all the abstracts we received. They did a great job synthesizing everything and bringing us today in a good presentation. Without further ado, I don't know, David, if you want to say anything else before we start? No?
No.
Great. Then in that case, I think the floor is yours. And thank you. Great.
All right. Hi, everyone. So thank you for this incredible opportunity so that we get to present the findings of the first round of our living scoping review on zero-dose children in low and middle income countries. And before I start, we want to acknowledge our truly exceptional team from Gavi and the University of Montreal who made it all happen. Next slide, please. Yeah, that's good. I mean, it's just a quick overview of the elements we'll cover in the next 15 minutes. You can go to next slide, please. So as you know, we need to have intensified efforts to progress towards the immunization agenda as target of reducing the number of zero-dose children by 50% by 2030. And before the increased emphasis on reaching zero-dose children with IA 2030 and with Gavi 5.0, only a few studies distinguished between unvaccinated and under-immunized children. And we looked for reviews on zero-dose children in low and middle income countries since 2020, and we found 3 really good, but we couldn't find any reviews that were, they were more enhanced focused on zero-dose children, but we couldn't find a comprehensive synthesis of the evidence on zero-dose children in all LMICs. So we decided to conduct a living scoping review on zero-dose children in all LMICs since the launch of IA 2030. And the intent is to repeat this on an annual or biannual basis until 2030. Next slide, please. So to be included, the studies had to provide quantitative evidence on zero-dose children and include data from LMICs as defined by the World Bank. We used an inclusive definition of zero-dose children. So we did not only consider children who are lacking their first DTP vaccine, but also other definitions that can identify children who are not receiving routine immunization services, such as children who receive none of the basic epi vaccines or none of the vaccines included in their national immunization programs. We focused on routine immunization services, so we only considered studies that were on supplementary immunization activities if they provided pre-campaign information. We included studies on children up to 5 years of age, as we wanted to be aligned with the big catch-up strategy. And our search strategies were designed by a research librarian, and we applied them on these databases you can see on the slide. And we looked for studies that were published between January 2020 and January 2024. Next slide, please. So we included primary research studies and reviews, and we considered preprints as well that were recommended by experts. And we excluded gray literature and conference abstracts and studies that contained only qualitative information. So we focused on the scientific literature, and these are inclusion exclusion. Next slide, please. So 2 independent reviewers screened titles and abstracts, then full text and using covidence. And in the end, we included 82 studies with 5 that were recommended by experts and 5 through reference list searches. We extracted the data using a pre-tested form that we developed for this review. Next slide, please. So in the studies and the 82 studies included, they provided good coverage of the Gavi segments in the World Bank region. So of course, articles may cover more than one segment. Next slide, please. And if of the 82 studies included in the review, We found 73 that reported on prevalence and distribution of zero-dose children, and 57 on barriers and deprivations faced by zero-dose children, households, and communities. So again, articles may cover more than one theme. Next slide, please. And 41 studies noted subnational variations in zero-dose prevalence. And an important evidence gap that we found was that we found no studies that were on interventions that focus specifically on the delivery of routine immunizations to zero-dose children. So the studies, when they documented interventions, they were either on supplementary immunization activities or on interventions that were focused or that were for under-immunized children, but that happened to include some evidence on reaching zero-dose children. And again, articles may cover more than one theme. Next slide. Yeah, thank you. We found 24 articles that were discussing barriers to vaccination for zero-dose children. 20 reported barriers related to intent to vaccinate, 10 related to community access, and 3 related to facility readiness. For intent to vaccinate, the most reported were myth, rumors, and fears surrounding immunization, lack of faith in immunization, and limited decision-making power for women and primary caregivers. For community access, the most reported were long distance and travel time to health facilities. And also important to note, there were 2 studies reporting access issues due to war. Next slide, please. And we found it, so a total of 44 articles discussed deprivations faced by zero-dose children, households, and communities. Of these, 11 provided findings related to access to immunization services, 23 to other health services, and 7 to other non-health services. Among health services, maternal health services were the most reported in terms of deprivations and lack of access. And then there were 41 studies that reported deprivations linked to other important indicators of development, such as low socioeconomic status, poor maternal education, malnutrition, and lack of access to water and sanitation. And important to note, several studies highlighted that the risk of deprivations varies importantly across contexts. So that means that not all zero-dose children are equally at risk of failing to survive, thrive, and reach their potential. And next slide, please. And Mira will present the 3 key findings and recommendations.
So by now we're sharing lots of things, so the mic is also shared. So I just wanted to draw your attention. There's a lot of evidence that was brought together in this review, and it was really exciting to see. Out of this, we picked 3 key findings that we want to communicate. So the first one is just to repeat again that the most commonly reported barriers to vaccination delivery for zero-dose children that were discovered in these studies related to intent to vaccinate, followed by community access. And this is important because if we take the hypothesis that the studies are onto something, that they're doing these studies because there's a real problem behind it, what it suggests is that system strengthening alone, immunization system strengthening alone, won't be enough to resolve the problem. In this particular case, we really need to work with communities to understand where the community may not have or maybe hesitating to participate, and also to understand the interface at which services meet the community at the last mile and those particular failure points. So it's telling us that it's always essential to strengthen services, but in this case, it won't be enough. The next thing that we wanted to underscore is the point that Audrey made very eloquently, which is that we do see that zero-dose children, households, and communities face multiple deprivations, but these have very different configurations in different places. So in some places, there are massive deprivations. People are deprived of everything. In other places, it's quite modulated. And so we need to be modulated also in our approaches. And the third thing was the lack of evidence that we saw about studies that specifically discuss interventions for reaching zero-dose children in the context of routine services. And we know that that is going to change soon because of all of the fantastic abstracts received. Next slide, please. So like any study, we have a few limitations that we would like to acknowledge. And the first is we were doing this. So our challenge was we started this with the goal of coming up with evidence in a way that would be timely enough, that it would enter the Gavi dialogue at a time that was useful for the development of 6.0 and its operationalization. So we were in a hurry, is what I'm saying. And because we were in a hurry and resources were limited, we could not do double data extraction of the full text of every paper. So the approach that we took was to say, if the paper is really about zero-dose children, try and prioritize that. So we have double data extraction on 42% of articles, but this is actually better than it looks because these are the 42% of articles that it's 100% of the prioritized articles is another way of looking at it. We made a choice to exclude studies that contained only qualitative information. So mixed methods are in, but purely qualitative studies were not in this round. And that was also just purely a choice due to pragmatism and timing. We thought that we needed to put the line somewhere, but that may be something that we would reconsider in future rounds. We also did not look at the grey literature. We focused only on the scientific literature. And the reason for this was also very pragmatic. We knew that syntheses of the grey literature were taking place in other contexts. So we didn't want to duplicate that work. And we did not conduct critical appraisal of the articles. Assessing the quality, the methodological quality of articles is optional for scoping reviews. And we decided to avail the option because of limited time periods. But this means that while we can tell you how many articles supported different claims, we can't tell you that the best methodology supported a particular claim. That's not something that we can do in this round. And once again, we may revise that approach in the future. Next slide, please. So coming back once again to what it all means, we have three implications that we want to put on the table, I guess, again. They're not new now. But the first is that we definitely need to take very seriously the obligation to partner with communities. And it always sounds good, but it is very hard to do in practice. And in particular, I think it's very challenging if you do it in a way which is time bound, looking for a result. Because once you start engaging with a community, there are other things that need to take priority, and the relationship that you build with the community takes some time to build and should not just be dissolved. So there are some real challenges to partnering with communities, but it is what we think we need to do if we want to address the root causes and contributing factors that shape low uptake. So if we just wanted to dive in and do something campaign-like, we wouldn't do this, but then we would be doing that all the time in repetition. If we want to get underneath to root causes and do something that solves them, it will take this community anchored approach. Next slide, please. So for the next slide, we wanted to come back to the concept that zero-dose children in mixed communities face substantial adversity, or many of them certainly face substantial adversity. On the whole, they do. And yet the adversity, the type, and the degree varies a lot from place to place. So the challenge is that we need to design strategies that recognize and can transform multiple deprivations. And these need to be feasible. That's often a big challenge because we're used to working vertically. And the challenge to work with other people or other partners to do something that is a common shared goal is it's not that people don't like to cooperate, but our systems are not set up that way. We don't have indicators that belong jointly. We have indicators that belong to different organizations separately often. And those are also contexts that we have to recognize. So this really is a challenge, but I loved what Alex said, that if every child needs to be vaccinated, that is absolutely true. But if at the end of this, what we'll have done is to prioritize vaccination alone, we will really have missed an opportunity. So we do want to highlight this. Next slide, please. And finally, of course, this one is well underway. We can see from the participation in this learning event, generate evidence on interventions that deliver routine immunization to zero-dose children and mixed communities, including their outcomes, cost effectiveness, and impact. So we know that evidence generation is underway. We would also like to see if there are different ways that it can be encouraged even more, perhaps by countries themselves undertaking some implementation research or something similar. It's a big orientation. Next slide, please. Of course, our thanks. So I want to thank, first of all, the dream team that Audrey acknowledged, and some of the amazing dream team members, Heidi and Gus, are here. It was really, really fun to do this work. It just went ahead and happened, so it was great. We also want to thank the many people from the Gavi Secretariat and the broader Alliance partners who shared ideas and suggestions and articles and lots of preprints with us, and the Canadian Institutes of Health Research for financial support. And please do feel free to reach out anytime. Next slide, please. That is it. Thank you very much.
Thank you, Mira and Audrey, for this presentation. Before we move on with Sunitha's presentation, David, you want to make a quick comment about the Zoom?
Yeah, just a quick comment that we're going to try to make this really interactive. We've turned off the chat feature and we'll now do Q&A. The way the agenda is built, it's not as much presentation as discussion. So we're really hoping for a robust Q&A.
Sorry,
David. Is that not working?
Yeah, it's red to work. Press. You can
Red.
remove the
Apologies.
Yes, working now.
We aim to have this very interactive. Turned off the chat feature. There's now Q&A that you're encouraged to use. We built an agenda that relies on a lot of Q&A. We recommend Q&A really be around recommendations and gaps, scalability, implementation, findings, how they relate to one another. We'll try to stay out of nitty-gritty about specific details of interventions or things that are published, but really try to take it to that level of how does this all connect? What does this mean for the community? So we're going to keep time pretty tightly. And if you look at the agenda, we do have quite a bit of time for discussion. So hopefully that's that'll be based on the questions that are put in. So thank you. Back to you guys.
Thank you, David. I think the key message is really active engagement in the Q&A box. If you have perspective to share them in the chat of the Zoom environment. I think even like for the people who are here in person, you can also do that through the Zoom, or like there may be an opportunity also to have some debate in the discussion session. In every session we're gonna have presentations followed by discussions, and really like the objective here is to get reactions, perspectives, even red flags, concerns, like whatever you think is relevant to share. It's really important that you bring in a really kind of a learning atmosphere, like openness and really like trying to bring the best of the Alliance to this event. So with that, Sunitha, we hand it over to you for your presentation. Thank you.
Thank you, Gus, and greetings to everyone, depending on where you're joining from. We are extremely happy to present the synthesis that we have been involved with. And at the start, we would like to thank Gus, Heidi, and all the team members, along with the Story Generation Consortium that Sabin leads. Moving on, in our first slide, we are looking at what are the presentation objectives. Next slide, please. So we are definitely sharing our insight. And this, like Mira and Audrey have already set the stage, we're looking at different aspects that have been adopted by countries in order to address the vaccine equity, because equity is central stage to all the work that's been going on from Gavi's side. We will also present, here it is cherry picking, some of the adaptive learnings that have come through in the abstracts. And then we will do a bit of a deep dive into integrated approaches and gender-focused approaches, because PHC-related and gender-focused approach also brings in a bit of community-centered aspects, which is, again, something Audrey and Mira have touched upon. So the dots are connecting, and it's nice to see the connecting dots. And we will also present findings and recommendations of the key themes that came through, because this will then connect to what's going to happen tomorrow. And that's how we connect the dots again. And of course, the summary, so we leave with certain crucial points that we are working towards. In the next slide, we have the country heat map, where we get a good diversity of countries, but we also have certain abstracts which spoke to things that were happening at a global level, things that were happening in low and middle income countries, so not just country specific. So it comes across in a very good diverse range. Next slide, please. So here we look at what is happening in terms of the point I just said about global level, regional, etc. What is interesting is, as much as later on, we will see that at a country level, certain progress may be reported. At a sub-country level, at a district level, sub-district level, that's where the small area-related discrepancies start to emerge. So it's good to have a lot of information that has come from district level, community levels, as well as health facility levels and going downwards. Next slide, please. And here, hope we come back to the equity reference group setting. And we see a good diversity here as well. So it's not just the urban poor, it's a good mixture of urban poor, conflict affected, remote rural, all of those coming through very strongly. Next slide, please. Here is our foundational point, because with this focal point, what we see is what is it that is happening when we look at the three triangles that we will come back to, which Audrey and Meera also touched upon. What is happening in terms of knowledge, awareness, and belief? What's happening in terms of intent? How are the communities? How are they preparing themselves? What is the cost? What is the effort that they have to put in for the immunization to be realistic? And then we come to the point of service. What happens in terms of the health systems? And what is the experience of care? And I will give you certain examples that comes through from these abstracts. And more important, what happens in the after service? What are the communities and caregivers experiencing here? Next slide, please. Now the dots start to connect really well. So Audrey spoke about, the intent to vaccinate, facility readiness, community access. So when we look at our 181 abstracts, they give us a good blend of what's happening here. So when we look at intent to vaccinate, we start seeing the misinformation and the trust issues that exist for the caregivers. We start looking at what are their concerns about the vaccine safety to start with, and then it goes all the way to also AEFI. When mothers and caregivers are unaware of how to handle what happens to the child with the AEFI, it leads all the way to gender violence at home. And especially depending on which countries we're looking at, where there's a lot of patriarchy, we see that male children are not vaccinated as much because they are precious and they need to be protected. So all of these things start to emerge when you start looking at these abstracts. We also look at how the ANC attendance has an impact. So if the service delivery has touched the mother in some way, and this is what, Alex, you brought in, it has to be a shared agenda. It's not just the immunization agenda. Zero-dose children just don't belong to the immunization domain. They belong to all of us. So if that is happening, then in some ways, if we have touched the ANC-related aspects and the PNC, the postnatal care, the antenatal care and postnatal care have such a crucial role to play here. And we also look at culture. That's something that we cannot discount. We cannot look at all the benchmarks that we can set up without looking at, in a human level, what are the cultural beliefs and what are the religious beliefs when it comes down plainly to that. So what are the roles that each group can play? Maternal autonomy. It is very easy. It's well and good to say everything rests upon the mother. The decision to vaccinate, the decision to take the child to the vaccination center, and all of it. But if the autonomy is lacking, then where do we connect the dots? The autonomy is, central to all of those decisions. Stigma. We see that teenage mothers and how the system deals with them, all the way up to bullying, etc., that happens in the Ugandan example. So there's a lot of stigma there. So how do we deal with that? Because that's what the mothers are dealing with. Community dynamics plays a role. What's happening in terms of what the family says, what the community says, and how does the mother have to bring in all of that into her decision-making processes, especially when the health literacy is what it is. Then we also look at the digital divide, because when we look at the digital divide, it happens across the gender, yes, but in case of women, it gets exaggerated. So it may be the same issue, unsafe roads is the same issue whether the father takes the child or the mother takes the child. But when it's the mother who takes the child, then it is exaggerated. The unsafe roads become more of an issue than when the male members can accompany. Community access comes in very strongly. So what is happening in terms of the facilitators, what's happening in terms of the acceptance and the awareness that happens in the communities. And I will talk more about this as we go along. Facility readiness. Now here is where the point of service, the experience, and the after service, all of those matter. It's not just about have we immunized? What is the coverage? Sure, that's a starting point. But how are we facilitating the communities to take into account that there is a system in place for the follow through? There is a system in place to help the mother understand that paracetamol needs to be given, for example. What are the guidelines there? Is paracetamol available in the healthcare facilities? So all of those start to matter. And here we cannot discount a lot of things. For example, the workload on the health workers. It's very easy to say empathy-based, sure. But if the workload is what it is, for example, if you look at Sub-Saharan Africa carries 25% of the global burden of diseases, and they only have 3% of the workforce. And we have to bear in mind that by 2030, we will have a shortage of 10 million workers. So how are we preparing ourselves for that? How are we preparing ourselves for the pandemic preparedness? All of that starts to play out here. Next slide, please. Here we have brought in who are the key stakeholders that have been identified in the abstracts. So it's a very good blend. A lot of this is known, so I will not touch upon that. I will touch upon one thing that came through very strongly because that was the only abstract from Uganda which spoke about barriers to reaching the zero-dose and under-immunized children, where it clearly said traditional birth attendants, despite being banned by the government, are approached by the communities. So if none of the other 180 abstracts are touching on traditional health practitioners, traditional medicines that can be given to children after immunization for AEFI, then that's a gap that we need to address, because we may not consider traditional health practitioners when they're not registered, when they're not qualified, but that's not what the community looks at. They are closest to the community. And that's the reason, that circle there is bigger than it actually needs to be, because from the abstracts, we don't gather it, but that's the reality that we have to note. And that's why when we look at that gap between zero-dose children and routine immunization, one way to address that gap is also looking at traditional health practitioners and how do we bring them in to, how do they find a seat at the table, at the decision-making table. Now, here are the cherries that we picked. It's very difficult to pick cherries when you have 181 abstracts. So adaptive learning. And just to give you a wide range of what was happening, in Solomon Islands, they used swaddle blankets, which had literacy appropriate.
Next slide, right?
Next slide, please. Yeah. Which had appropriate immunization messaging. In DRC, the youth took a very active role in the U-Reporter platform, where they were going to communities and finding out why was the vaccine being refused. And in Nigeria, they had catch-up policy restrictions, so their catch-up policy is under review. Here's an interesting one from Mali, where they looked at the routine immunization strategy in conflict areas, which was led by the National Center for Immunization. Nigeria gives us an excellent example where they looked at the National Basic Guide to Routine Immunization for Service Providers, and they said the content is overwhelming. The content is not in a language that majority of the healthcare workers can understand. The content has limited data on zero-dose children. Content also does not speak to zero-dose identification and outreach. So they are pointing or highlighting where the next steps lie, and these are good lessons to learn from. Next slide, please. Now here we start looking at more dots that start to connect. Now, here is an interesting concept that came from one of the abstracts. The title of the abstract is at the bottom of the slide. They spoke about multi-zero-dose indicator. So what it says is, if children have or their mothers have somehow been reached through either the facility delivery, postnatal care, DTP, vitamin A supplementation, then we start looking at how children can possibly be reached. What is very heartening here for all of us who have spent decades in this area in different ways, may not be just immunization domain, but in different areas of health sector. Half of these zero-dose children are not multi-zero-dose. So that's heartening. So, like Helen Keller said, if we face the sun, the shadow is behind us. It's not that we're ignoring the shadow, but sometimes we need to see the glass half full. So that's very heartening to move on with. Next, please. This is where the PHC integration comes through. So whether we look at individual countries like Somalia, Sudan, Ethiopia, that have increased the touch points in order to overcome service delivery barriers, to the literature review on the zero-dose children, which looks at how do we reach the sustainable development goals by having PHC integration that takes place. And we look at Gavi-led zero-dose learning hub in Nigeria, which came up with the webinar series for what are the best practices in integrated services. Whatever we are looking at in this area, they are all pointing towards the same North Star. We need to look at PHC integration. We cannot do away with that. And like Alex and Hope started us off with, this is a shared agenda. Now we go to the findings and recommendations. Now, when it comes to the findings and recommendations here, next slide, please. So let's start with the gender considerations. If we are leaving out 50% of the population, especially the one who has to go through the pregnancy and give birth, then there is no way we are going to reach the immunization agenda that we want. As much as maternal autonomy may not be existing for the majority, we still have to bring them to the table. So what it says very clearly is it is disproportionate. The vaccination responsibilities are disproportionate. When the child has AEFI, who is looking after the child is disproportionate. The non-consenting father, especially when fathers are older, it starts to become a problem. They are not ready to consent for the vaccination of the children. It goes all the way up to gender-based violence at home when the male child comes down with AEFI. And that's also something to be, that we have to bear in mind. But there was one very interesting abstract which looked at the reporting bias. And it kind of questions us and steers us and nudges us in the right direction. If maternal agency and education is what is getting all the, if the microscope is on only these two aspects, and we are completely leaving out male decision-making on childhood vaccination, then we are not headed in the right direction. So that's a very interesting abstract that nudges us to look at what are the interventions when it comes to male decision-making. There are several interventions ranging from storytelling to extending vaccination hours, gender-sensitive outreach, etc. And ASHAs, the female community health workers in India that are driving these processes, and female vaccinators in Somalia, Pakistan, Nigeria, etc. Ultimately, where are we headed? Research has to happen with the gender lenses. It has gone on in a very neutral lens, but we have to look at the gender lens and directly engage with decision makers, whether it is the male member or the mother. We have to look at it. Most important, what comes through in the abstracts is the clear need for gender disaggregated vaccination data. So that's really important. Now we move to the next slide where we look at role of community. So this is where we have to spend a little bit of time, because what have the different communities done? For example, in Mali, they have Mama Yalin, which is a community level women leadership program. These women do house-to-house visits. They do a lot of things in order to follow up lost cases. We have in Tanzania where the community leaders are working so that at different levels, they are institutionalizing it. So they're looking at permanent vaccine agenda at a high level in the council meetings. They have institutionalized constituency level where they engage with community leaders and all the way down to house. So they are doing it at different tiers and ensuring that things are moving forward. From various countries, ranging from Malawi to Madagascar, we look at local leaders, religious leaders, women, youth groups, etc. participating. Then there is a very interesting scoping review. And in the scoping review, it again nudges us in a different direction. What is it that is lacking because of which women leadership in immunization is not seen? When you look at health sector and education sector, women are the majority. But when you look at leadership in both these sectors, women are in the real minority. So there's a very interesting WHO document that says, delivered by women, led by men, pun intended for the first part. So that's again a very interesting one. Next slide, please. We move on to what's happening in digitalization. So in digitalization, we see a wide range of aspects, right from HERAMS, which is the WHO's Health Resources and Services Availability Monitoring System used by Yemen and Central Africa. We look at India and Nigeria, where they have used predictive modeling, geospatial analysis, etc. There are examples for digital monitoring and multi-source data dashboards, which come from diverse countries such as Ethiopia, Sudan, Afghanistan, and others. And in countries like Uganda, Mali, Bangladesh, we see how they are documenting improved immunization coverage by looking at real-time reporting and tracking through their systems. But what are our recommendations? We need to enable the digitalization environment. As much as the environment needs to be enabled, and we have to also understand that ultimately everything happens at the grassroots level. We have somehow been terming that the last mile. But is it the last mile, though, is a question we can ask ourselves. Is that not the first mile? If things start falling into place in the first mile, then we won't have as many issues going up the ladder. So maybe we have to call it the first mile and say, how do we take our vaccinators? How do we take our community health workers who have very low literacy? And how do we enable the digital system so that data is captured right at the PHC level, sub-center level? And in India, for example, we have what is called as the Anganwadi centers, etc. So we have to go deeper down into the grassroots if we want to actually get this going. So it's all about the granular data, everything happening at the grassroots levels. And we have a lot of recommendations coming from abstracts which speak to digital identity of the newborn. So if the birth registry can be connected, and if we start tracking the child from that point onwards, a whole lot of systems start to fall into place. Gender disaggregated data, I spoke about it earlier too, but I thought because we need to keep bringing it back into the agenda of thinking and doing, it's a good one to have. Multi-source data dashboards have been shown to be working in several countries, and that's coming through strongly. And real-time monitoring, that also comes through strongly from some of the abstracts. Next slide, please. Now we have to start looking at where is the glass, half empty? Scarcity of costing information. We may know quite a lot of what is working, how to make it work, etc. But what will it cost? And how will the government sustain these costs? As long as they are supported, that's one story. But when they're not supported, what happens? So in the periodic, the PD system in India, they have costed it. It was a costing study where they looked at incremental cost per dose delivered was USD 6.21, and incremental cost per zero dose child reached was USD 82.99. Now, are these sustainable costs? Are these costs that can be scaled up at sub-district levels, etc.? Those are the real questions. There was a scoping review where, again, it gave a very diverse view. The cost per additional dose was USD 0.08 for a cellular phone contact, which was done in Kenya, whereas when we go all the way down to Nicaragua, the cost per dose for a cash transfer intervention was USD 67. Now that's, again, not sustainable. So this is what the scoping review brings about. So there are several gaps in this area. And what is important to bear in mind is there is lack of well-designed studies. So when we don't have well-designed studies, then how do we benchmark? And even if we benchmark, how do we contextualize? What works in Nicaragua is not going to work in Kenya. What works in Kenya doesn't work somewhere else in Asia. So that benchmarking has to be at a country level, which is contextualized. So we have to look at the recommendations that come from the abstracts, which is support cost analysis capacity building. It is also about funding costing research, because without understanding where the money has to be put in, we won't have the evidence that we need. Next slide, please. Funding flows is again another aspect that brings a lot of common findings, gaps, and recommendations, mainly the timely disbursement of funds and how do we enhance financial tracking mechanisms. Because we see that, abstracts from Nigeria spoke about significant funding left unspent. We also look at how, the delayed payments resulted in complete increase in the number of zero-dose children to 62%. So these are different evidences that come through from countries that speak to funding flows. Next, please. Vaccination catch-up is, again, a key area that came through from some of the abstracts. They speak about how the catch-up campaigns are happening, but the absence of the national catch-up policy results in problems. So Nigeria is one of those countries where a catch-up policy is in the final level of approval. Next slide, please. AEFI findings, again, I spoke about this earlier, but this is again something to bear in mind, because if the caregivers have to understand how to handle these aspects, then we need to understand, where do we start in the first mile that we are looking at. Next, please. Urban settings are again a key area that came through in the abstracts. What are the systemic barriers? Where are the mobility challenges in certain countries? What are the service disparities that we see? Long service wait lines, the queue in the healthcare systems, etc. And the recommendations that come through from there range all the way from the micro plans that we need to what kind of women empowerment and collaborative services that we need. Next, please. Demand focused also comes through very strongly in some of these abstracts, because whether we're looking at what's happening in Bangladesh, which is lack of male engagement in family health decisions, to what's happening in Kenya in terms of a mistrust of government-led health campaigns. These are the various findings, and certain recommendations that came through strongly is how do we build trust through local community leaders? So again, going back to the first mile. Next slide, please. Outreach to campaign delivery spectrum. Now, as much as we look at what are the different challenges, whether it is health worker shortages, Ethiopia's abstract spoke to us about it, or Kenya's challenges in logistics and supply chain, etc. They have also given us where are the recommendations, where are we headed next? So how do we strengthen the supply chain? How do we introduce routine follow-up visits after the immunization campaigns, etc.? And like I mentioned earlier, climate shocks are a reality. Migration of well-trained staff are also a reality. So how do we look at the 10 million health workforce crisis that we are going to have in 2030? And also the sub-Saharan Africa, which bears the biggest burden of the global burden of diseases, with the smallest number of health workforce available for them. And Asia comes after that because of the population that we are looking at. Now, next slide, please. What are the studies telling us?
Just to match the slide you're presenting, Bruno, it's the next one, I think.
Yeah.
The next one with the colors.
The colors, yeah. What are the studies telling us? So digitalization is coming through very strongly in most of these abstracts. The need for having tools that are effective, that can be scaled, that are sustainable, etc. The next aspect that's coming through is also the gender-specific barriers. So in gender-specific barriers, we look at what's happening in terms of maternal autonomy, what's happening in terms of the gender digital divide, how do we meet those kind of challenges? Because those are not just up to the healthcare systems. So health system strengthening alone is not going to address that. Some of those come from the social determinants of health. So how do we make it an overall approach, so that in that overall approach, Sustainable Development Goals are the common agenda that leads all of us to the same shared goals. If we want to look at the humanness in the human design or the human-centered design, we need to look at what are the models of care that are being followed and what's happening in terms of the primary healthcare systems, and how do we integrate primary healthcare into all of the immunization work, because vertical slices of the cake is not going to bring us to that shared agenda. We need the horizontal slice of the cake where we look at where are the common goals and how do we reach those common goals, specifically by ensuring that country-specific benchmarks are available, because one specific benchmark in a different country will not lead us to these to the operationalization of these aspects. The next one here is also on how do we engage diverse stakeholders, because in one of the slides I had shown the known knowns, whether it is community leaders, religious leaders, whether it is the different levels of decision making that happens before the intent to vaccinate is operationalized by the caregiver, we have to engage with all the stakeholders, specifically at the community levels. So community engagement is something that has been spoken a lot since 1977 with the Alma-Ata Declaration. We have come a long way from there, but how do we sustain what is being done? That's the critical part. How do we scale up what is being done? Because whatever we see are those exceptional examples, but how do we make it happen across the board, across the countries that are facing these problems? And the country-led examples, the community-led examples also show the same, intensity. Yes, there is success, but that success happens when there is the funding that allows those things to go on. And when the funding is not a part of the system, then how do we still keep it ingrained, embedded in the system? So those are the challenges that we have to address. The last, but never the least, is what is going on in the conflict and the humanitarian zones, because what are the strategies we have there? How do we align to what are the requirements there? For example, in one of the examples, we see how communities took a key role in working with the healthcare system in giving access to children who are in the non-state army-controlled areas. So that's where the communities played a crucial role. They would work with the healthcare professionals, and they would, talk about the routes that they have to take, how do they safely get back, etc. So we have these excellent examples, and they are steering us in the right direction. There's a lot of learnings that come through. And towards the end, what were some of the advantages that we had when we went through this work? One of the first advantages we had is the co-creation that happened between Gavi and us. So the consistent inputs we had helped us move the needle. The second one was the progressive approach, because before we came here with the synthesis of the 181 abstracts, we have done 2 webinars. So in the 2 webinars, in the first one, we looked at what is it that we learned from abstracts that spoke about identify in the IRMA framework. And in the second webinar, we looked at what do we learn from the reach abstracts and the cross-cutting abstracts. So then this is the third step, where we're looking at what is the synthesis. So while it is progressive and excellent, we also have to look at the disclaimer that time cannot be catalyzed. So within about a month's time, all this has been going on. So it is the best of what could be done within that month with all the co-creation and everything else that came in. The other limitation we also have to bear in mind is possibly the word count, because when the abstract have to look at the word count, sometimes the author would say, they have looked at gender specific aspects, but you will see the word gender appear for the first time in the recommendation. So possibly they have worked on gender specific aspects. Maybe it hasn't come through because we are only looking at the abstracts. So that's also another limitation we have to bear in mind. But overall, this is the big picture, and we are very happy to have presented it to you. Thank you.
Thank you very much, Sunitha, and thank you, Mira and Audrey, for your presentations. We're going to open now a session of discussions. And we do have a number of questions already in the Zoom. And I am going to bring some of them for you to kind of comment. And if you feel like you don't have all the answers, we can actually bring other panelists to kind of also bring perspectives on that. So I think one of the first questions we had was for Mira and Audrey related to the barriers that you identified. And if it's possible from your study to parse out what is actually prevalence of barriers, then authors' perspectives and availability of data in the study, in the literature, in the published literature. Yeah.
I will start, and then Mira can complement. So we really, as is the scoping review, we reported on the number of studies that happened to report. So I would say more availability of data. For the barriers, it was what was captured by household surveys, let's say, from these studies. So it was really more like frequency counts. And then we categorized in the intent to vaccinate, community access, facility readiness. But then again, we really took the wording that was reported and these studies. And then Mira, if you want to complement.
Sure, I'll just add something that we noticed. A lot of the studies use DHS mixed data. And for the studies that use DHS and mix and took an interest in categorizing barriers, there is some ability to say that those studies are representative to whatever the data set is designed to represent. But of course, the data collection then is a little thinner than if one were to design the study oneself. So there are pluses and minuses. So excellent question. And basically, we can catalog more than we can talk about prevalence.
And if I may add, it's 40 studies out of 79 primary research studies that we're using DHS mix and large scale surveys. So it's important to think of other data sources to get answers. Thank you.
Thank you. Thank you very much. There is another question now for Sunitha related to existing a fair amount of studies that shown that for the most part, there are no major discrepancies in immunization rates by sex, boys and girls coverage in the world. Why is this a recommendation to push for gender disaggregated vaccination data? What's the evidence that would drive this recommendation?
Thank you. A very interesting question. Yeah, when you look at the social and the cultural norms in a country, I think that's where the differences start to come through. When you look at it from a neutral aspect, then a child is a child. But when you look at it from a cultural point of view, where the male child is seen as more precious and the consent is not happening, and the father is trying to prevent vaccination, and when the mother takes the child secretly and gets the child vaccinated, and the child will invariably end up with AEFI. So when there is fever, when there's crying, and all that happens, it ends up in gender, the domestic violence that takes place. So in those kind of settings, it starts to become important to look at if there is that gender distribution that is not as neutral as it is supposed to be, then it is important to have disaggregated data. But in countries where we don't see that, then maybe, that's why we are talking about contextualizing everything. What works for one country doesn't work for the other. So keeping a track of social norms is one thing that leads us to understand where it is more important. And maybe that's a way forward. Gus, back to you.
Thank you. Yeah, I think this is a discussion we had at Gavi like multiple times as well. Like it's a good question, I think, because if you look at that from DHS and mixed surveys and across the globe, there is no specific national level country that has a statistically significant difference in coverage between boys and girls. But when you start looking at specific communities, yes, you can see these cultural norms. And then if that emerges, something that we really need to keep track. I don't think there is a recommendation to kind of include that disaggregation in kind of a admin system, in regular admin systems. That may come with the EAR, like when countries go that direction. When you have individualized data, we know the struggle for countries to kind of put a disaggregation of these kind of sex data from the boy and girl in the tally sheets, and that becomes burdensome and can decrease quality of data collected. But I think, and I also think like one of the key strategy shifts in 5.0 is the gender related barriers, but that's mostly related to caregivers, cultural norms, to health workers, distribution and leadership positions, and these is another level of gender related barriers rather than the specific boys and girls disaggregation that we know in most countries may not be a big issue there. There was another interesting question on the proportion of abstracts focused on human resource for health and healthcare staff development. How important are the human resource for health dimensions to the zero dose agenda? What are the gaps in evidence with respect to HRH? Sunitha, you would like to comment on that if you have that? I know it's a lot of abstracts. I don't know if you have these specific proportion in mind, but can you comment on that?
Yeah, we will catalog and get back with more details. That's a first step among the long list of things to do. That will be one of the important ones to do. But when we also look at, what are the gaps and what are the recommendations coming through countries, I mean, the abstracts are definitely talking about the shortage of the work staff. And when the shortage and how the caregiver experiences whatever happens in the healthcare system, it all has a ripple effect. So it's an important one to come back with more details. Thanks.
Thank you. Yeah, and I from what I remember, from what I read, like there is a fair number of abstracts discussing human resource for health issues. I don't know the proportion exactly, but in generally there is kind of a general statement that there is a lack of human resource for health, especially in these pockets of zero dose children. They talk about retention. They talk about like other issues. It's clearly an issue. It's clearly a barrier. But yeah, I don't know, like I don't think it's being quantified adequately, and I don't know the proportion of abstracts that mention it. I don't know if anyone else here would like to come with any insights on HRH. Ale, please.
So, thank
introduce
you.
yourself first. Thank you.
Yeah, sorry. So I'm Ali Turab. I'm from PHC Global, and we are collaborating with Sabin on this particular project. So since due to my work in the HRH on other projects, I can tell you that in Pakistan alone, the WHO recommended HRH is not there, proportion for population. So there is a lot of task shifting going on, right? So in a lot of communities where there are not enough vaccinators, which are your frontline healthcare workers to vaccinate for at the health facility level and also at the outreach level, they are engaging the lady health visitors, which are like nurses, right? So there is a lot of task shifting going on, but particularly with the eye on immunizations, I think there is paucity and dearth of work in this particular stream, that how HRH is affecting the immunizations. So that data is not there. That is not even published. So even if we go to and have a review of gray literature, even in gray literature, we will not find enough data to answer these kind of questions. But yes, studies are recommended, more research is recommended to find out that how task shifting is affecting the service delivery at the last mile level.
Thank you. So let's go for another question. There is an interesting question here about the external validity, the generalizability of the findings, which I find very exciting, because this is in the core of what Gavi does and what we're trying to do in the Alliance. As expected, countries will have different sets of key drivers for a child remaining zero dose, and thus will need varying levels of engagement. A global conglomerate of recommendations may be of limited utility unless we clearly group the recommendations according to country region segments, according to key determinants of the zero dose problem. Sunitha, would you agree with that? Do you have anything to say from what you read in the abstracts on that?
I think it makes a lot of sense to look at, where are those recommendations coming from, and look at it from a country specific or a region specific aspect. So yes, there's a lot to take back from there. Thank you.
Great. If I might react a little bit on that comment, because I find it very interesting. And I think we need to think of that, in my opinion, at least, like as kind of a context typology. I think it's less about the region, it's less about the country specific, it's more about the kinds of barriers they're facing and the types of like communities that we are trying to kind of manage. I think if we use kind of a theory behind it, and then that's the approach. I think the Zero Dose Learning Hub is going to talk a little bit about that. That's the approach we are taking in the Zero Dose Learning Hub. As long as you have a clear set of like assumptions and theories, and you understand your context very well, and if something works in a similar context with facing a similar challenge, there is a high likelihood it's going to also work in other countries. So it for me it's less, of course, like there is a regional similarity, so barriers may be similar across some regions, but I think we should not look at that through kind of a regional eyes, but theory-based eyes. Like, what are the issues at stake? What are the problems you are trying to solve? Are those problems similar across different settings? And it's very likely that in the same country, we're going to have like different types of communities and different types of problems you're trying to address across different pockets of zero-dose children. So, and that may require adaptations of the strategies at a more granular level than at the country or regional level. So that's, I don't know if anyone else would like to kind of chime in here or have a different perspective on that. Tove, please.
I won't preempt the presentation that I'm going to give later, but I think that that's very much in line with kind of what we're finding, that there's some really important contextual aspects that you can find across, even within countries. Those contextual pieces are so important for being able to kind of understand what the barriers are and what are potential interventions that would work.
Yeah, and to complement that, I think it's really important that we research, the implementation research, states out these contextual issues very clearly if it's to be used in similar settings. Because if they don't bring that up in front, like it's going to be very hard to generalize the findings. Like if we don't understand the context in which the solution was implemented, it's not enough to present results. Like we need to understand the results based on like what was it intended to be done, and then like finally like is it working in that type of context or not?
Should be these last two there for Sunitha.
Right. There is another one for you, Sunitha. Wondering if there were abstracts that explore methods to measure the prevalence of zero-dose children with robustly and timely at different levels of the health system, including district service delivery levels. This is important to design interventions and monitor their effectiveness. Do you remember like the different measurement approach for zero-dose children in the abstracts?
So one of the abstracts which came from India was on the small area prevalence. So they spoke about how at a national level, even with the DTP coverage, it's quite good. You know, it's like 90%. But the more you go down into the granular levels, that is when you start seeing the problems, the discrepancies, and what is not working. So that was definitely one abstract which showed that at a national level, you see a lot of progress and growth. But the minute you start looking at granular levels, then you see the problems.
Great. Yeah, I think we're going to have a lot of opportunities today as well to discuss the measurement issue, because that's coming again and again. There is also like we're planning to give a lot of attention on that, between like what is a catch-up, what is a routine, what is like a prevention of zero-dose children when it's embedded in routine immunization versus when you are trying to catch up children that have been missed across multiple years. There is different measurement approach. That one of the lessons that we got also like from all this work in the last years is there is a need for flexibility in the measurement according to the needs of the health system. I think the spirit of the strategy is really about trying to reach these missed communities, finally identified and reach them, and not only once, but with full immunization and other primary healthcare services in an integrated way. But we know that to do that, we may require different approach in measurement according to the health systems. Yeah, Ali, please.
So, so Gus, we also need to see that, you know, a lot of this data previously was coming from MICs and the PDHSs, right? And these huge, large-scale surveys, they are sort of powered to capture this kind of prevalence at least at the district level. But when you talk about sub-district and the smaller administrative unit level, the geographical units, I think they are not powered enough. That is one. But looking at the flip side, a lot of the zero-dose data, I'm not talking about the abstracts, I'm just talking about the sake of discussion, that how it is happening in these countries. So a lot of the zero-dose data, the number of zero-dose children is coming from the polio program efforts, which is then communicated to the routine immunization systems, which is the EPI. So I think the data is there, because when you talk about prevalence is a point estimate, but what is better? The better is that knowing the real number. And the polio program sort of during their SNIDs and, you know, other initiatives, they actually have the real number. So, I mean, in terms of that, we are okay. It's all about, you know, knowing those communities, the nuances at the ground level, the cultural things, why they are living under the radar, and then targeting, having those strategies for them to accept vaccination. So it's more towards that. I was just thinking out loud.
Thank you. There's another one. I think, Sunitha, there's a lot for you, actually. There's a little bit less for the living scope and review. I think people are really excited about these abstracts and they want to learn more. And just before we go into the questions, just to let you know, we've shared the full list of abstracts with the attendees. You can also go in the database and filter. There are columns on the right where you can filter like the gender ones, the one with results, the one in urban areas, the one in conflict areas. So you can do this filter and learn by yourselves if you are like really interested in doing a deep dive in those abstracts. But then there is a question about availability of data in the abstracts related to gender. Sunitha, the question has any abstract tried to do an association between gender disaggregated data and variables like maternal education, location of vaccine administration, etc.? Like, was there any kind of I think we already discussed that the gender disaggregated may not be so relevant there, but was there any other association of these kind of a maternal education and other variables that you remember?
I mean, they came through in the recommendations more than just what was happening. But it's worth it's worth the time to go back and look at some of the things that is drawing the attention of the people who are asking these questions. So it would be worthwhile to go back and check what is it that we saw when we start looking at what methodologies were used by the different countries and how do we classify them. So it's a next step to be done.
On that one, I think we actually found quite a bit in the published literature. I think the association between socio-demographic factors such as education, often the parental education, the father's education was not included, sometimes because it's not available in the data sets in the same frequency as maternal. So emphasis on maternal education is often due to the fact that it's the data we have. It doesn't mean maternal education is not important, but very good evidence that maternal education is an important determinant, that socioeconomic status is still an important determinant, and that the intersections of these things are likely to be areas where we can pick up people who are at higher risk.
Great, and I think Deep is also going to talk about associations and like a zero dose and other like PHC and other factors that may be related to also gender related barriers. So keep tuned for that discussion later today. There is another question about measurements to you, Sunitha, again. Do any of the papers share what a proxy for fully immunized childs from zero dose or under-immunized child status? For example, they try to give an example to clarify. A setting like Somalia would consider DTP3 or MCV2 as a fully vaccinated child, as after the first year, it is hard to catch up vaccine on those, as they are on the move, have competing priorities, are at risk groups. So I think the question is like different countries have different vaccine schedules. They have different denominator issues that populations may be on the movement. Was there any discussions on how to better measure these kind of proxies for zero dose and under immunized, or that you remember from the abstracts?
Nothing that's coming to my mind quickly on that as a proxy, but especially with respect to the catch-up vaccination, that is where they spoke very clearly on that countries such as Chad, etc., don't have a catch-up vaccination policy, and also they don't have policies where beyond 2 years the vaccination can happen. So that's where some of the projects were looking at big catch-up, which were for children from 2 to 5 years. So that came through strongly from the Sahel region.
That's great. Yeah, we made a lot of discussions on that also in the learning hubs. We're going to probably talk a little bit about that in the upcoming sessions. I think there's a lot of confusion still like on like the zero dose measurement component. Maybe it's worth like giving a quick kind of a drop now before we start the day. I think as a kind of a general strategic indicator for Gavi, we consider zero dose children as the children who don't get DTP1 after 12 months of life, like from 12 to 23 if it's coming from a survey. But like when you use like the admin system, is the consideration is like 12 months of life. And that's because if the children lose the vaccination by 12 months, it means they are likely, there was some analysis being done, and it's likely they are not going to receive the vaccine after that, or there's going to be a very little catch up after that. So this is a proxy for a mixed community, right? This is marking a health system failure to reach a specific child, and it's a kind of a health system proxy for that. It's imperfect. It's very, very imperfect. It's too late to take action, like 12 months. It's very late. Like we don't want countries to be using these kind of an indicator operationally in their kind of a everyday business, because probably it's not going to give adaptive data, like data that it can manage and act upon. Having said that, it's really important from the global level perspective to track it. And it's for our level, for like Geneva global headquarters level, this is really important, but we do acknowledge there is a need for flexibility at the country level. When it comes to under-immunized, it's really complicated because countries have different schedules, they have different priorities. It's hard to track. Sometimes you have problems with the Penta vaccine that maybe being a proxy for other problems, not the kind of the HSS systematic reach for communities. So we know there is a need for flexibility, and we know from what I remember from the abstracts, there was quite a number of different ways to track populations in movements using like digital enabled approach. There was quite a different number of like birth cohorts, like 0 to 12. There was 0 to 5. There was 0 to 2. That I remember, like from what I read, like but again, like this is very contextual. As long as the spirit of the strategy is being kept on like trying to reach these mixed communities with whatever data is available in the country level, it's still like very valid and may spark good discussions and good evidence on understanding these barriers and how to reach these communities. So is there any other?
Yeah, there's a number of questions, but there's also questions in the room.
Okay, so I will, before we continue with the questions in the Zoom environment, I would like to open here in the room for some questions. Yeah, Laura, please.
Yeah, thanks. So I just wanted to thank the presenters for really great presentations on interventions that might work, and ask how, as a community, will we be documenting those interventions that aren't working? So I assume people that are implementing interventions that aren't working, they're not publishing in journals, they're not submitting abstracts. And so how are we going to document those lessons learned that are really just as important for us to know? So either stuff that's just not working at all, or things that work in certain settings but not in others. And to what extent are researchers and Gavi grant are encouraged to actually report on that and be transparent about what's not working, so that we can all learn from that? Thank you.
Those are good questions. I don't know if you want anyone specifically to kind of answer that, or
Not really,
kind of
just
a
for us
question
to
for
all think
debate.
about.
Just have a comment to what Laura said. So Laura, I was thinking on the same lines, because a lot of this work which is being presented here through the abstracts, they're not through the zero dose learning agendas from those countries. So that is why when they were classifying, you would see that, they've mentioned stuff which may not have been the core methodology, but they have used that language, that kind of language. So it also draws attention to the fact that a lot of this work is also piggybacked. It is not zero dose specific. For example, one abstract on my left from the IRD, I was working at IRD when this work was happening, and that was not focused on the zero dose. Rather, it was focused more on vaccinator performance by using GIS and GSM systems that are the reaching their posts and working and stuff and like attendance. So it does draw attention to the engagement of extended partners at the country level, like the WHOs and the UNICEFs, who are well aware of the zero dose agenda, and then further streamline the work and the research coming out of those countries, which is not specifically funded by Gavi, targeting zero dose. So some of those facts, and these are also for us to consider, that the abstracts, they are not coming out of purely zero dose focused studies. There was huge work, and then the researchers just saw that, okay, what is related to zero dose, which I did in the past, and they sort of went towards that and published.
Just before each one of you speaks, like, please introduce yourselves, because people may not know in the virtual environment who is talking.
Yes, good morning. I'm Logan Brenzel with the Bill and Melinda Gates Foundation as a consultant. I guess I also really appreciated these two presentations. It really lays out kind of the landscape. But as a kind of quantitative person, I actually was interested to know, do we know the size of the effect? Do we know the size of the role that each of these barriers are playing, or do we know the size of the results of any of these interventions that have been implemented? I think it's one thing to describe what seems to be working, but knowing kind of the relative size of the effect, I think, will help us in thinking about which ones should be scaled up.
A quick response.
Sunitha and then Amira, because
Yeah. So the easiest response here is building on what Ali said. So it's not like, we are comparing apples with apples. So every abstract is coming from a very different angle. And then, it is not looking at the same elements in the same way. So that's one problem, where it is very difficult to quantify them very quickly and then move forward. Nevertheless, we have to go back and look at which were those abstracts where statistics has played a key role and methodology describes those key roles. So that would be the next level of synthesis, which looks at, where do we see that kind of evidence come through, where it is more quantitative, less mixed methods, and less of desk review, etc., that has led to it. Because in those kind of abstracts, we will not have anything that speaks to the effect and the size of effect. So that's a very important aspect to look into. Thanks.
Thank you. I just wanted to add quickly, just to underscore, the published literature is always behind what's happening in reality. So in the published literature, we didn't actually find any studies that had measures of intervention or effect. We found studies that were quantifying barriers and problems, and some of those I think are quite reliable, understanding that they're done in a specific context. And coming back to the paper from Sindh, it's also a very, very good illustration of use of digital data that's available in the Zindagi Mehfooz database. So it is a secondary analysis, but it does show us the power of, once you have those kind of digital infrastructures, how you can answer questions in a way that's really programmatically powerful and relevant. So I think I just want to give it a positive spin, as well as accepting and agreeing with the comment that you made.
Grace, please.
Thanks.
Introduce yourself, Grace, please. Sorry.
Oh, sorry. Hi, everyone. My name is Grace Chi. I'm with USAID's Momentum Routine Immunization Transformation and Equity Project at JSI. I think that's a really great question, but it also makes me think back to, most of my experiences in health system strengthening, how difficult that question really is. Because, it's one intervention, the context is completely different every single time you apply that intervention. And there are so many different factors that come into play that, unless we can do it 100 times, I don't think we can, quantify those answers very well.
Please, Tov.
I wanted to add, it's related to several of these points, but I'm also struck by the 197 abstracts that you received and thinking about Hope's comment of like how much growth in this area has increased and also the lag in publication. But I imagine that there are going to be a small number of these that will ever actually be published. And so I guess there are two questions that I have for kind of Gabby and this group. One is, what are the opportunities to follow a lot of these studies? Because I know many of them are still in early stages. And so there may be data that comes out around effect size and things like that that we don't know yet. But secondly, are there any of these abstracts that seem really promising, that are the types of things that we might want to think about how we further support or follow? Just kind of wondering if there are some bright spots within these that are things that we want to continue to build on. I just think it's incredible, the sort of energy and momentum, and I'm curious how we will maintain that and continue. Thank you.
So this was my exact comment. Thank you,
Wow.
Toad.
Sorry, just please introduce
I'm so
yourself.
sorry.
Yeah.
Yeah, sorry, guys. So I'm Judith Robb McCord. I'm with Sabin Vaccine Institute, and I appreciate your comment and the question as well, Logan. I think that we have a phase 2 here, quite honestly. And I think that one of the things we need to do is eventually look at the full paper from the abstracts that are kind of the most promising and the most robust. Poor Sunitha is going to faint and fall out of her chair, but we will back you up. So anyway, I do think that that's a phase 2, because I think there is a lot to be learned if we can dig in behind just the abstract. I think that was a real limitation, as they were abstracts. And so we couldn't really dig into more information. Thanks.
I agree with that. I think we have a great breadth with a short depth. Like we were not able to get all the details of like the different studies. We had to go with this abstract model to gather the information. But we know there is much more available from where those studies came from, and it's probably a good idea to kind of follow up on that. Just to say, I think from what I read from the abstract, and I went through all of them in details, there is not a lot of kind of a prevalence, not a lot of like a robust quality quantitative statistical analysis. There is a wide variability of methods to understand the barriers, which may be influenced by the outer bias, like what they perceive as importance, what they are trying to measure, and that's also there. Having said that, there are some common barriers in the qualitative components and even in the quantitative that come across different typologies of zero-dose communities, which I think we should potentially elevate. Like those are the ones we know are there, and everybody's talking about them. So this is what we know now. Like I think it is still a gap to understand like the impact. I think the best tools are helping to overcome that gap because they are giving a kind of a framework that everybody can follow with the same method, the same structure to try to quantify some of these barriers. And we're gonna learn more about when the best tools start. They are starting now to get some results, but when they get more kind of established at a global level, we're gonna start having more quantitative results on the impact of those barriers across different countries and communities. For now, we don't have that yet, and think it's a gap, but I think we should act on what we have. And what we have is like, there are some common barriers that we see across these different communities. And I think that should be elevated to our kind of a strategy or operationalization level, in my opinion. Yeah, go ahead, Alex. You want to?
Yeah, thank you. So it was incredibly rich. My head is spinning, which I think brings me to a little bit one of the findings, which was, I think, from Nigeria, that actually poor health workers get overwhelmed by the amount of complicated information that comes their way, and there's a lot of great insight in here. And if we gave this to a health worker, I think their head might go from spinning to exploding. So I guess the question I had was, how do we really tease out what's already known and what's not known? Insofar as I think there are some things in here which pretty well known and understood and reflected often in guidance or tools and materials already exists. And there are some things which are new. And I think one of the things I'd love to hear a bit more on is what really jumped out as this is really new. This is different. This is not something we've been talking about. We've been seeing before. so that we can zero in on those specifically and talk about how do we take those lessons to countries rather than taking everything to countries and overwhelming people. The other question I had was, someone mentioned ERG contexts, and it's always sort of struck me that we talk a lot about the ERG context, and yet the best modeling we have shows that I think a bit less than half of the zero-dose children are in those three contexts, which when you think about it, if you exclude remote, rural, urban, and conflict, it's like, you'd expect, and in a way, it makes me question almost the validity of the ERG context, because that actually accounts for a large share of the population. So you expect it to account for a large share of the zero dose. And so did you learn any more through Akit or these studies and abstracts about where the zero dose children actually are and are there contexts we're missing?
You want to?
I was just going to say from some of the abstracts that I read is on identify and reach specifically, we know that they, conflict in humanitarian settings. And there was some really interesting findings around urban, especially the peri-urban areas. There were communities of under-immunized and zero dose. And that was also related to communities that were from displaced populations, people that had moved either from within a country or into a new country. Is that correct, Sunitha? Do I remember that right?
So, yeah, if you look at, adding to that, I'm also keen on understanding, what is the next way forward. For example, I'll take an analogy because it helps me state what I want to state. For example, when we look at the antimicrobial stewardship that is happening, we look at what is happening in the various countries. Just between 2015 and now, the countries were asked to work on their national action policies. The countries were asked to align to the global action plan. And therefore, you see a lot of momentum that's all going in one direction. So in a similar way, I think maybe it makes a lot of sense to go back and look at what is the immunization policy in each country. In that immunization policy, what are the different elements that maybe from a global agenda the countries have taken into their policies? And what do we see there? Are countries looking at each of those indicators? And if they are not, then where are the potential gaps that can start at a policy level? And then by the time you percolate down to the first mile, how do they start to, exaggerate? So maybe that's one way to also start looking at it, where from a policy angle, what has percolated from the tops down, and then what has gone from tops down to, sub-district levels and healthcare facility levels. Yeah.
Mira, please.
Thank you. Just to add to that, speaking from an abstract that one of our teams sent, which was on small area variation, but I think this confirmed something that many people know intuitively, which is that when coverage levels are very high, zero-dose children are hard to find and kind of, I don't want to say that they're everywhere, but they are in more places than you would expect because the coverage is very high. So the challenge has to be understood in terms of the health system, just as Gus was saying, and we'll have different ways of approaching it at different stages. But as the coverage gets high, it becomes more and more that you're looking at the first mile level, and that the higher levels, the aggregates are doing reasonably well. So the challenge is, how do you leverage existing services to get to them?
Audrey, and then I think we'll go back to the room. Sorry, Tom, because we are going to have opportunities to discuss tomorrow internally. I want to give also opportunity for people who are virtually contributing.
And also we found several studies that highlighted the power of geospatial modeling at identifying using risk factors and also using indicators of that would indicate lack of access to services, to other health services, let's say, that really helped to identify these pockets at subnational level and even in areas of high coverage. So those are really promising and to scale up and look into.
Thank you. Just to react quickly to what Alex has said about the validity of the ERG settings, I think if you take, I think the DTP1 indicator is a proxy for mixed communities and a poor proxy, we know that. And if you think about that on a kind of a non-ERG settings, like you're going to have high coverage and you have a large number of like areas, and it's going to be a large number of zero dose children, absolute numbers. But when you think about these settings, the urban poor, the remote rural, then you have low coverage. It's easier to kind of focus. It's probably like where like the HSS bottlenecks are. So I still see, I know that we're not going to move the needle on the DTP1 indicator so much if we do that, because a lot of this DTP1 is outside of this setting, but I still think is a good kind of a prioritization criteria for the zero dose, because I think a lot of the mixed communities, they are really in these settings indeed. So coming back to the virtual environment, sorry, I just want to give them the opportunity, because we're gonna have opportunities to discuss internally. There was a question about Gavi transition countries in the virtual room. Any specific lessons to take from them? Does the transition context have different implications for zero dose recommendations? I think Sunitha can try to bring, like, if there was any kind of a discussions on countries transitioning out of Gavi support, but we can open a little bit the discussion as well. Okay, so I don't remember any abstract talking about transition countries, like from what I read. But does anyone wants to? I do think there are implications for the zero dose, especially for the alliance approach. But I don't know if anyone here would like to come in on that. No idea. Go ahead, Mike, please.
I can say one of the things that's come up.
Present yourself first.
Oh, hi, I'm Mike Bryson. I'm with VMGF. I know one thing that's come up around some of the health system strategy is the question of, as countries approach transition and are reliant on Gavi support potentially for zero dose, what is the role of Gavi support in avoiding backsliding versus reaching that last community or those last communities? This is an important, I think, strategic question when we talk about zero dose and we step back from just the immediate context of how do we reach more communities, but we recognize that this occurs within a context of external funding that comes into governments. What is the conditions that are associated with that? And as countries transition, where should the priority of the alliance be as a part, but as a zero dose partner on the ground, how do you anticipate potentially the withdrawal of Gavi funding? And this gets to points around advocacy within the IRMA framework, which is something we haven't, is sometimes in the kind of neglected portion of the IRMA framework, but raises some interesting questions about how we bring that in, because zero dose, as Gus, I think, has really called out, is reflective of a failure of a health system, and transition is the removal of a crutch or a support structure that countries benefit from. How do we anticipate that and plan for it, particularly when we know that many countries are in a challenging macro fiscal situation these days? So there's not an answer there, but I think this is probably one of the main inflection points of the A component of IRMA, is how do you anticipate and advocate for this in the context of a government funding structure?
That's great, Mike. And just to note, we have very little evidence on advocacy in the abstracts, like really kind of a gap there. I would say advocacy is not only about like the budget, but also like about like raising the voice of these mixed communities, bring them up front, ensuring that they are finally like front and center and at the core of the political will of the country. So this is something that we still need to learn a lot about. Go ahead, Hope.
And just to say, I think this is where data is important also, because for the advocacy with the countries with really constrained budgets, I think the question that Logan asked is going to become even more important, right? There's growing populations to be covered. There are more things, that the health system needs to do. Where is the most bang for the buck, and then how do we bring that into the advocacy? I think this is a really critical thing that we should come back to. Yeah.
Great, and we are at time.